Welcome, everyone. Welcome to the next Newborn Toolkit webinar. Today's topic is Fighting for Our Future, Climate Risks, Realities, and Responses for Newborns. Welcome. Please introduce yourself in the chat. Next slide, please. Welcome once more to the Newborn Toolkit webinar focused on climate to mark World Earth Day. The Newborn Toolkit is a multi-country, multilingual learning for high-quality small and sick newborn care. In 2024, we had over 55,000 unique users from over 170 countries, and it's all thanks to our global community of neonatal advocates and workers linking together on this platform. So we have over 1,000 tools in 11 languages, technical content in French, linked communities of practice in English and French. And the whole goal of the toolkit is to drive change for newborn survival that cannot be met without small and sick newborn care. Next slide, please. Welcome once more to the Implementation Learning Seminar Series so that we move faster together. Today's topic is Fighting for Our Future, Climate Risks, Realities, and Responses for Newborns. We're thrilled to have you join us today for what promises to be a dynamic and informative webinar. Today, we'll be diving into this very interesting topic with our dynamic and fantastic list of speakers. On your slide now, we have QR codes for Newborn Toolkit newsletter in French, in English, and a QR code for our social media channels on Blue Sky, Twitter, LinkedIn, and Facebook. And just to note, this webinar is being translated to French, and we encourage you all to share it with your French-speaking communities working in the newborn health space. Next slide, please. All right, so for upcoming webinars, we have an exciting lineup this year. Next month on 13th May to mark World KMC Day, we have a Kangaroo Mother Care Focus webinar, which will dive into duration, nutrition, and data that matter. So we ask you all to add this to your calendar so that you can join us. And in June, we'll also be exploring other topics such as neonatal data and dashboards. Next slide, please. And just to flag that our webinars are translated in French. So for our French users and French community, you're welcome to join us for these webinars as well. Next slide, please. All right, so I'm your host for today. My name is Dr. Mbozo Sipalo. I'm a Zambian clinician working in the newborn health space. I am also the knowledge management co-lead of the Newborn Toolkit and the co-host of the Global Neonatal Podcast, which is a podcast that aims to unite and share insights from newborn health workers and advocates working in resource-limited settings. So I invite you all to check out our podcast and link in if you'd want to be featured. Please post your comments and questions in the Q&A section of the webinar. And once again, thank you so much for joining. Please do introduce yourselves in the chat. Next slide, please. All right, so as you can see on the slide now, we have a fantastic group of speakers who are going to share deep insights on climate change in the newborn health space. As we all know, both hot and cold temperatures can have quite detrimental effects on babies and newborns and pregnant mothers. So all these speakers will explore that and share insights on the work that they're involved in. So our first speaker, next slide, please, is Dr. Etienne Liangbios. He's the team lead for evidence and knowledge at PMNCH, that is linked to the WHO. He is a medical global health and epidemiologist specializing in maternal, newborn, and child health. He has expertise in implementation research, evidence synthesis, and knowledge uptake. His focus is on improving health outcomes for vulnerable communities and has over 20 years of global health research and intervention experience. He's worked across UN agencies, academia, government, and civil society organizations. Very excited to have you here join us and share your knowledge about the climate space for newborns. And over to you, Dr. Etienne.
Thank you very much, Botu. It's a delight to be here. Congratulations to the Newborn Toolkit team and to partners for addressing this very important, this very contemporary issue. I want to start with the image that we're looking at on the background. This is from Burkina Faso, where I had a chance to live and work for a long period of time. And in Burkina, the vulnerable communities are really grappling with a wide area of extremely complex challenges. In the northern part, there's an active conflict that is unfolding, and the day-to-day reality for those communities is really one of grappling with poverty, access to water, quality nutrition. Now, on top of that, Burkina is a landlocked country in Western Africa, and they are recording increasingly high temperatures, often above 45, particularly in the hot season. So they're really dealing firsthand with the reality of climate change. So for vulnerable populations in Burkina and similar settings, climate change is not a looming threat. It really is the day-to-day life, and it has impact on the health and well-being of the most vulnerable, including pregnant, lactating women, and newborn. And this is what we're going to look into today. Next slide, please. So there's really evidence on the impact of climate change across the life course on all stages. And what do we talk about when we talk about climate change? Well, first of all, it's really around climate hazards and risks. So we're looking at rising temperatures, but also disasters, floods, droughts, wildfires, windstorms. We're really witnessing this every day. There's really an increasing number of disasters and climate-related events. There's obviously the link to air pollution. We'll get to that on the webinar also. And then challenges like sea level rise that are linked to salination, for instance. So the salination of both surface and groundwater. So really, we're documenting the scale and the scope of this problem on a daily basis. There's also direct impacts of climate change. So changing disease patterns, for instance, we're seeing an increase in zoonosis, in vector-borne diseases, including malaria and dengue, and that has an impact on maternal newborn health outcomes. We're also seeing indirect impacts through major disruptions to essential services, threatened livelihoods, the problem of displacements, of migration. So really, we're talking about a perfect storm here on the impact of climate change across the life course. Now, that being said, we also have evidence that pregnant, lactating women and newborns are particularly vulnerable to climate change due to the unique stages of their life course. Next slide, please. So if we look first and foremost on heat and the impact on newborn health, there's really a growing body of epidemiological evidence on the association of high temperature with maternal newborn health. We're talking about 24 systematic reviews that exist today in that space. The table that we're looking at summarizes the association between heat and maternal newborn health outcome. The one that is most documented is the impact on preterm birth. So looking at a recent meta-analysis, we're seeing a 16% increase in the odds of preterm. When you look at heat wave days versus non-heat wave days, there's a dose response association in that space vis-a-vis increased levels of temperature and longer duration of heat exposure. And we're seeing also inequitable distribution of effects, where the most vulnerable are hit the hardest, including households with the lowest socioeconomic status. There's also a strong link with stillbirths, 24% increased odds in a recent meta-analysis, and also an impact on low birth weight. Yet there's a dearth of data in that space on LMICs, but we are witnessing a large scale impact on numerous newborn outcomes. Next slide, please. If we now look at air pollution, this is a really important issue. The main driver of climate change is fossil fuel combustion, which is also the major cause of outdoor air pollution. So that's really a critical aspect where we have very strong evidence linking air pollution, including exposure to fine particle matters, to newborn health. Again, if you look at the state of the evidence, there are 47 reviews that exist in that space. Preterm birth being the most investigated outcome, again, but really also strong association with low birth weight, and also association with congenital anomalies, whereby the most reported is cardiac congenital anomaly. So that really is a key aspect that we need to address in terms of policy response. Next slide, please. If you look at some of the causal pathways, this is evidence that is still being built with some knowledge gaps, but we do have strong links with aspects around reduced placental blood flow, oxidative stress, an increased inflammatory response with increased markers for inflammation. So that really has an impact on different perinatal outcomes and also newborn morbidity and mortality. Next slide, please. So I mentioned some of the extreme weather events that we're witnessing every day, cyclones, hurricanes, flooding. This really has an impact also on maternal and newborn health. So if we look at maternal stress, for instance, we're really seeing a strong problematic there. That has an impact on newborn health outcomes. There's more limited evidence, but there is evidence on the impact on preterm birth, on fetal distress. I mentioned indirect impacts of displacement. This really is putting newborns' lives at risk. And then disruption to feeding practices, for instance, with lack of privacy, stress, exhaustion, limited fluid and nutritious intake. All of that has a bearing on exclusive breastfeeding and sustained breastfeeding. Next slide, please. So I think we have now high quality evidence on the various impacts of climate change on maternal newborn health outcome. What I'd like to argue and focus on right now is really the fact that we need more solutions. There's really a need to drive the policy response to this problem. We have the arguments in terms of impact on newborn health. Now we need to shift gears towards solutions and evidence-based approaches. Part of the solution is around mitigation. So the mitigation agenda to preempt climate change. Now, obviously, this is linked to reduction of fossil fuel combustion, to reduction of transport emission, promotion of clean energy, including also clean cooking solutions. And we're just not moving fast enough in that space. And this transition towards renewable energy, actually in some settings, and we're also seeing this every day on the news, we're going backwards in that space. So I think we really need to shift gears here. Similarly, this question of fossil fuel subsidies and financing, this is always a critical issue at the COPs, the COP meetings. It is still a huge part of the problem. There's tremendous subsidizing of that industry. So we're actually subsidizing the impact on newborn health, which is problematic. And then the question of how do we actually reduce air pollution? We need to strengthen regulation in that space and really mobilize more efforts and resources around mitigation. Next slide, please. The other side of the coin is that climate change is happening. So we know that we also need to make sure that we move towards adaptation measures and that newborn health is mainstreamed in climate adaptation strategies. So that's true, for instance, in terms of prioritizing packages of essential interventions of emergency newborn care in national health adaptation plans and disaster risk preparedness strategies. There's also a need for vulnerability risk assessments to really understand the threats to newborn health in different contexts. The question of emergency, I alluded to that, making sure that packages of newborn health emergency are embedded in preparedness and response plans. Making sure that we have better data. We need epidemiological surveillance that's looking at the impact of newborns and how to document the effectiveness of the interventions, the adaptation interventions on newborn health. Making sure that our health systems are more climate resilient. So training healthcare workers on the impact of climate on newborn health, preparedness for heat waves, cooling centers, air conditioning. My colleague Deborah Jackson is going to delve a little deeper in that space. And then issues around vector control, vaccination programs. So really mounting a strong response by the health system. Similarly, supporting communities, making sure that there's strong community leadership and engagement, including through nutrition support, social protection schemes, and a wide area of community-based interventions. Next slide, please. So this is the last slide to really shine a light on this issue of prematurity. So we've looked at the tremendous impact of climate change on preterm birth. Preterm birth is still the leading cause of neonatal mortality. So it's really critical that we address that agenda from a prevention and a care perspective. We launched recently the Born Too Soon report to really advocate for greater policy and resources in that space. And one aspect around climate change is really to have a strong intersectoral response to this, including intersectoral financing. So that means social protection schemes, earmarking revenues for carbon taxation, for carbon trading schemes for maternal newborn health, and then also leveraging existing climate finance for maternal newborn health co-benefits. This is a very difficult time in history with tremendous fiscal constraints. So I think we need to be smart and innovative in the way that we look at financing, including other sources of financing for maternal newborn health, like pandemic and climate financing. So all in all, I want to close with a message here, a message of hope. We do have the evidence, we have the tools to address this problem. What's required now is really that we take this agenda seriously and that we mobilize policy efforts to protect the most vulnerable, including newborns. Thank you very much.
Thank you so much, Dr. Etienne, for that really insightful overview of the threat of climate for newborn health and mitigation pathways, and flagging the Born Too Soon as a good resource for people to explore how to change the climate space for newborns. So from that very insightful overview, we'll now be honing in with Dr. Deborah Jackson, and her talk will be on evidence for climate effects with a focus on babies, neonatal units, and what to do. Next slide, please. So Dr. Deborah Jackson is the inaugural Takeda Chair in Global Child Health at the London School of Hygiene and Tropical Medicine. She held the role of a Senior Health Advisor and Chief of Implementation Research and Delivery Science Unit position, Health Section at UNICEF. She's an extraordinary professor at the School of Public Health, University of Western Cape, South Africa. She's got qualifications in nursing, public health, epidemiology, biostatistics with over 160 peer-reviewed publications. She serves on several global and WHO advisory committees and has lived and worked in Africa and Asia Pacific. So she has current research on climate, heat, mothers, and children's health. Please do post your comments and questions in the Q&A section of the webinar. And over to you, Dr. Deborah Jackson.
Okay, there. Hello, everyone. Thank you so much. Thank you to Mbozo and the NEST team for inviting me, and Dr. Etienne for the great introduction and overview of what's happening in climate and health for mothers and newborns. I'm going to speak more specifically on the newborns themselves and then neonatal units and what we can do. Most of you from NEST 360 are working at some level of neonatal care. Next slide. So starting with the NEST 360 thermal management module, as we worry about, keeping our babies warm, and that's what most of it talks about, is the temperatures less than 36 degrees at birth, and it being a risk factor for death. And as I'm also a neonatal nurse, we always worry about our babies being cold. And we know that babies lose heat through 4 main mechanisms: evaporation, radiation, conduction, and convection. So all neonatal staff know about these things. Next slide. But as Dr. Etienne noted, the world is getting warmer, and not just warmer, hotter. So, and in our field, we've always worried about protecting our babies from cold. But what about the baby being too hot in the face of climate change? Next slide. So here's a paper from Brickstad and Neckstad et al. From 2022, starting to think about how climate change may threaten our newborns. Dr. Etienne's already spoken about the fact that we're going to see more preterm babies. We're going to see more sick moms. But you know, neonatal health down there in the green box, specific to neonates, is heat stress, dehydration, increased mortality, and low birth weight and preterm, as he already said. So we are very concerned about having both more preterm babies, but then those babies being at risk. Next slide, please. So they also talk about in that paper the newborn physiologic responses to heat, not just to cold. We know that neonates have a limited ability to both to temperature regulate, both hot and cold, and they're more vulnerable because of large body surface weight versus weight for both hot and cold. And what we're seeing as in the research, not even for that we're going to have more preterm babies, but when it's hot, even small changes in body temperature can increase the risk of neonatal mortality. We know that elevated core temperature may induce apneic episodes and sudden death. Anybody who's been a NICU nurse and had a baby get too hot under a warmer and they stop breathing, that's pretty common. And but we're also seeing mortality from non-hyperthermic causes that can also increase during hot weather. So it's not just, you know, the baby being heat stressed. There seem to be other impacts. Next slide, please. So this is some as yet published preview data. Coming attractions is from a colleague, Paul Lockaball, that's working with us, and he's done some work on the demographic and health survey data and countries from East Africa. And you know, this isn't as refined a data coming from the DHS as we might have, but it still already shows that extreme heat or extreme cold in the past week will have impacts on mortality, on neonatal mortality. And depending on where you are, those impacts can be quite different. And I think it's important to recognize that depending where you are is something that we really have to think about. Next slide, please. So we mentioned beyond mortality, we are also seeing, you know, reductions in growth. So across, you know, all these age groups, 6 months to 24 months, we're seeing that when it's above 28 degrees Celsius, that we see reduced growth. And so that's obviously going to contribute to general mortality if you have a baby who's lagging behind in growth. So it's not just heat stress. And even in the previous slide, that was all-cause mortality. So kids were dying from a lot more things in general. Next slide, please. I found this paper, I wouldn't call it exactly historic, it's from 2012, but I think, you know, 2012, we weren't really thinking about climate change and heat the way that we are now. And sorry, my doorbell's ringing, I'm just gonna ignore it. And so basically, he talked about that classical management of neonatal thermal neutrality in Africa. It's been dominated by basically what's been handed down from industrialized societies, with different climatic factors, different social advantages in the countries of origin. And I think that's the great thing about NEST 360 is that your whole mantra is moving that technology appropriately to Africa. And so when we start to think about that, when we think about the microenvironment for the newborn, we must begin to modify it when we think about regional climate changes to another of room temperatures in excess of 40 degrees Celsius. So we've got to, and I've been in hospitals where it's 40 degrees Celsius, and I'm sure many of you have as well. And so I thought it was interesting that in his algorithm that he includes monitoring both heat and cold of the newborn. So we have to think about that. Next slide, please. So what do? It's really a measure of balance. We've known all along cold is bad for newborns. It's kind of, you know, put into our minds, but we now have to start to realize that hot is also bad for newborns. The WHO recommends a body temperature of 36.5 to 37.5, and NICU standards generally recommend a thermal temperature of 22 to 26 in the room, as well as relative humidity of 30 to 60%. So if you're in a hospital ward that's not thermal controlled and it's 30 degrees or 35 degrees and 80% humidity, you're basically dealing with the problem. And I think one thing to remember is that whatever the temperature is outside, if you're not in a thermal controlled environment, the inside temperature, so in our hospitals or facilities, is generally going to be at least 5 degrees warmer. So we have to pay attention to thermal regulation, both hot and cold, something that's kind of new to all of us. I'm not so worried about the small and sick newborn in a thermal controlled NICU that's, 25 degrees in a warmer with a working temperature probe. That basically attentive care should protect both from both hot and cold. I'm more worried about, in many of our facilities, healthy newborns and small and sick newborns when the environment is not thermal controlled. Okay, we must pay attention to the environment. Is the ward hot or cold? We have to note the airflow. We have to note the humidity in the room. We must still keep our babies wrapped, but when it's really hot or really cold, we need to pay closer attention to temperature monitoring so that if it's really hot outside and we've got a baby all swaddled up, we want to make sure they're not getting too cold. So you need to monitor them. You need to pay attention to whether they're sweaty or fussy, they're lethargic, not eating. All of those things we know, but they could be because they're too hot or too cold. And so we have to assess them and act. And we can't forget about the mothers and the staff. And my colleague Pascalia is going to speak about the impact of these hot temperatures on staff and their quality of care. Next slide. We must consider structural adaptation, which Dr. Yaten was mentioning when we talk about national adaptation plans. We have to think about adapting our actual facilities to protect our newborns, the mothers, and the staff. So you can see, typical facility on the left in the heat, it's very hot inside. Whereas after, we can also make, and these aren't expensive structural changes, painting the roofs white, planting trees, having fans, having windows, having water, even moving to solar so that we can keep places cool and warm and at the appropriate temperature. So these are the kind of things we need to start to think about in our maternity, our NICUs, our hospitals, and community health centers in general. Next slide, please. So I want to thank everyone, thank our funders from High Horizons, thank all the partners in this particular talk from the London School. And please visit our website where you can learn more about what we're doing to address heat and maternal, newborn, and child health in both Europe and Africa. Thank you.
Thank you, Dr. Deborah, for that very interesting account on how we can have structural adaptation measures in health facilities to reduce indoor heat. That was a good way to conclude, to give some action points for newborn health workers to assess and act. So now we will explore more actionable steps with a country example from South Africa. And the topic is heat impacts on perinatal staff and actionable steps. Next slide, please. So we have Dr. Pascalia Munyewende. She's a senior researcher, social scientist, climate and health directorate at WITS RHI. She has expertise in journalism, media, migration, and displacement training. She is involved in research and program management, bridging climate change impacts on health across multidisciplinary teams in Africa, Europe, UK, and USA. She's a PhD holder in health systems and policy with 10 years directing meaningful and impactful projects focused on vulnerable populations. And she's a science communication specialist in evidence synthesis and translating complex research for maximum public engagement impact. So a very dynamic researcher that will be exploring actionable steps. Over to you, Dr. Pascalia.
Thank you so much, Mbazu, for that nice introduction. And thanks to Etienne and to Deborah for setting the scene. Good afternoon, everyone. I'm excited to share our findings on the effects of heat exposure on perinatal staff in South Africa. So our research highlights the critical intersection of climate change and neonatal health under the heat indicators for global health, or the High Horizons project, as it is known here in WITS RHI. Next slide, please. So in this presentation, I'm going to walk you through our research, which examined the work environment, the impact of heat on perinatal staff, their well-being, their performance, as well as the quality of care and the health system overall. We also going to look at some of the actionable steps that we can take in response to heat exposure. So in our research, we used a mixed methods approach. We included ethnographic observations, in-depth interviews. We also did time motion. We carried out surveys as well as thermal monitoring to gather comprehensive data. But to note that we're still busy with analysis of data from all of these methods. So what I'm presenting here is just a tip of the iceberg, or rather a small flame. Next slide, please. So our thermal monitoring revealed concerning levels of heat exposure during the study period, and especially in the antenatal rooms, in the delivery wards, and in the postnatal wards. Next slide, please. In terms of the temperature and the air movement in healthcare facilities, when we conducted the surveys, we found out that 58% of our perinatal staff reported that the temperature in the clinics as well as in the regional hospital was very hot. And they also complained that for those that were working in confined areas where they were crowded as staff members, they ended up being very exhausted or very fatigued. In our ethnographic observations, our researchers also noted that on hot days, staff were very lethargic, they were less energetic, and this was due to the impact of heat, and it also affected their productivity. We also observed that healthcare workers were using files to fan themselves or stepping outside to get fresh air. And one of the healthcare workers noted that we can feel it's hot in our office, it's hot in the ANC ward, and the patients are packed. Next slide, please. Another significant theme that came out of our study was the exhaustion and fatigue that healthcare workers felt because of heat exposure. Again, the ethnographic studies showed that healthcare workers often experience feelings of fatigue and exhaustion, especially during periods of high heat. And one of the staff members said that heat drains me, and that when it's too hot, you just push the production line, and it also affects the quality of care. Next slide, please. We also noted severe dehydration and thirst amongst healthcare workers. Some healthcare workers reported that they became so thirsty at work that they could not wet their mouths with saliva. And some also reported that when it was very busy in the clinics, one tends to get dehydrated. This particular healthcare worker noted that, let's say on days where we have 13 to 15 deliveries, it's not like you have time to take many water breaks. Then you can become dehydrated or feel unwell. So healthcare workers reported to us that they were reluctant to drink water because if they drank water, it meant that they would have too many water breaks, and it would mean they have to go to the toilet too many times, and that this would affect teamwork and the flow of work. So healthcare workers ended up being dehydrated at the end of the day. Next slide, please. Heat exposure also affected the mood and the irritability, as well as the comfort and productivity of healthcare workers. Some healthcare workers became so frustrated that they wanted to quit, and some felt that it was just intolerable to work in the hot environment. In the IDIs, for example, this healthcare worker said, now this room is too hot and I'm getting hot here. I cannot tolerate working in this hot temperature. So this basically highlights for us the breaking point of healthcare workers who are working in these hot environments. Next slide, please. We also noted that heat exposure also affected the cognitive function and quality of care for healthcare workers. Because they had severe shortages of human resources, sometimes they would miss the quality of care for patients. And this healthcare worker, for example, reported that in December, I saw a patient, and the patient is a previous cesarean. We were supposed to refer the patient at 34 weeks, and it was very hot in December. We were only 2 on duty, 2, sometimes 3. We missed that patient. We missed the referral of that patient to a high-risk clinic. So we see that heat not only impacts perinatal care staff, but it also affects the quality of care that they deliver. Next slide, please. We also found that the heat influenced the timing of activities for healthcare workers in healthcare facilities. And sometimes when it was hot, healthcare workers preferred to postpone some of the activities to times when it was cooler during the day so that they could avoid doing certain tasks in the heat. Healthcare workers also mentioned that when it was hot, they tended to be slower than usual in terms of the quality of care that they're delivering. So, for example, where tasks were supposed to take 5 minutes, sometimes they would take more than 5 minutes. Healthcare workers also reported feeling very hot and sluggish when it was when the temperatures began to rise. And this healthcare worker, for example, mentioned that if it's too hot and you're feeling a bit sluggish or tired, you tend to rush through things to get things done faster. It's not like you're going to stand there for 20 minutes talking to one patient. You're just going to go in, do what you need to do as quickly as possible. Next slide, please. So in terms of communication, our survey data revealed that during heat waves, there was a noticeable decline in communication, both with patients as well as amongst the staff. And so during the last heat wave, the majority of healthcare workers reported that there was poor communication between themselves and the patients, as well as with members of staff. And so this healthcare worker said that there would be less communication. In the morning, you will start with asking long questions, and then your questions become shorter during that period. And one healthcare staff also reported that, when I come in for the 3rd time and find the patient doing the same thing, I will just scream. That's what we do. So this healthcare worker was referring to her coming in and trying to get a new mom to breastfeed a baby. And the new mom was reluctant to breastfeed because it was very hot and because of the bodily contact that comes as a result of breastfeeding. She was reluctant to do that. And so she says that as nurses, when they see this happening, they become very frustrated and they end up shouting at the patients. So this breakdown in communication, it can have very serious implications for patient care as well as for teamwork. And it also highlights, the heightened frustration and the stress levels that healthcare workers go through because of heat exposure. And so now, before we move on to the actionable steps, I think it's important to acknowledge that, the effects of heat don't only occur in isolation in these healthcare facilities. We found that there were several confounding factors that can influence how heat impacts staff as well as the quality of care. So for example, I mentioned earlier that, the staff shortages, the high patient volumes, and also we found that the building design of some of the healthcare facilities also exacerbated the heat. So in terms of air movement, this was very difficult because some of the windows were high up, they would remain closed. Most of the facilities did not have functional fans. There was no water in some healthcare facilities. And so all these issues coalesce to interact with heat exposure. And so these factors can amplify or mask, the true impact of heat, making it even more challenging to address. So it is important for us to understand these confounding factors because they help us to understand that a comprehensive approach is needed, one that not only addresses temperature, but the broader work environment, as well as the systemic healthcare issues in healthcare facilities. Next slide, please. Okay, so with that in mind, we've identified in the High Horizons project some short-term actions that we can do to improve, the effects of heat exposure on healthcare workers, and this included ensuring that healthcare workers can access drinking water at all times, improving ventilation, as well as to implement scheduled water breaks or rest breaks. Also, importantly, to educate healthcare workers about the impacts of heat stress. And then more long-term, we are advocating for systemic changes, such as investing in climate-resilient healthcare facilities that are essential for protecting the staff well-being and maintaining high quality of care, especially as the heat keeps increasing every day. So we are planning to advocate for the investment in cooling infrastructure to make sure that healthcare facilities have got more air-conditioned wards as well as clinics, to also advocate for building modifications. Healthcare workers indicated that they would appreciate having more windows in their healthcare facilities. They would appreciate more open spaces that are less crowded, as well as advocating for the inclusion of heat stress in occupational health protocols. We are also advocating that, if possible, healthcare workers or perinatal staff can be provided with lighter protective work uniforms. And we are also busy planting trees in healthcare facilities. Next slide, please. Just to acknowledge the High Horizons project, as well as our funders, the European Union, for funding our project, as well as our project partners. Thank you very much.
Thank you, Dr. Pascalia, on sharing the big impacts heat has on perinatal steps, and those really simple actionable steps that can definitely be implemented by facilities in resource-constrained settings. Very, very insightful. So now we'll jet off to Pakistan and learn about climate change and newborn health, what can be done pragmatically. So we have Prof. Zulfi Bhutta, founding director of the Institute for Global Health and Development, Aga Khan University, co-director, Center for Global Child Health, Sick Kids, lead research groups in Toronto, Karachi, and Nairobi. And his work focuses on scaling up evidence-based community interventions and global implementation of reproductive, maternal, newborn, child, and adolescent health interventions. Very excited to hear about your work, Prof. Zulfi, and over to you.
Thank you very much, Mabuzo, and thank you for my colleagues for setting the scene. I'll dive right in. And next slide, if you can look at the way climate change impacts health and nutrition outcomes for women and children. There are both direct impacts, indirect effects, as you can see. It's already been alluded to through ecological changes, impact on air pollution, water quality. And these are all modulated by pre-existing social conditions, social deprivations, living conditions, and the realities of lives for many women and children in rural, remote populations. And all of these are extremely important in the context of maternal newborn health, development, and nutrition, because they all form a continuum. And what is often forgotten in the context of climate change is that the impact is not just related to changes in temperature or changes in acute heat waves in both urban and rural settings. It's also climate-related disasters. And I'm going to largely focus my discussion on the latter, just given their consequences in the geography where I do a lot of my work. Next slide. If you look at how climate impacts pregnancy and outcomes, as I've mentioned, a lot of this has been discussed already. There are aspects of exposure in early pregnancy middle and late pregnancy that relate to outcomes as hard as mortality and as consequential as fetal growth retardation that may have impacts that cascade throughout childhood and are affected, as I've mentioned, by living conditions. One aspect of climate change related problems for newborns that has not been a focus of discussion, next slide please, so far, has been the effect of the combination of heat and humidity on several aspects of newborn outcomes that relate to things like infections and also relate to propensity for adverse outcomes during the period of lactation, early feeding, and care for the newborn infants. That's one of the reasons why the mortality aspects of climate change in relation to newborn outcomes is not just related to the early newborn period. It forms a kind of a continuum that continues throughout the newborn and early infancy period. So one big challenge in many climate-related emergencies is how do you deal with not only small vulnerable newborn births that are taking place at times outside of facilities and in community settings, but how do you deal with many of the complications that may arise from lack of services to mothers and to newborn infants that relate to common disorders such as infections. Now, next slide. We want to talk about the huge crisis that occurred in Pakistan in 2022. These massive floods called by the UN Secretary General as monsoon on steroids. Next slide. If you look at what really happened in that particular disaster, a third of the country was impacted. And a lot of the southern part of the country, which is also happens to be one of the poorest parts of the country, people were just displaced, and not just displaced for a short period of time, displaced for almost a year in many circumstances because everything that they had was washed away. And this is just one illustration and an example of what happened. In quantitative terms, next slide, we documented that right after the floods. Around 33 million people were affected. Half of them were children. And of the 1,700 deaths that were recorded in the first couple of weeks after the floods, around a third were in children. 600,000 pregnant women were affected by the displacement in that acute circumstance. And in addition to schools and health facilities, many of the first primary care network clinics and birthing places were also destroyed. And a big challenge for us in that circumstance, next slide, was really how do you make services available to people who were destitute and in real difficult circumstances, and what was to be done for mothers and newborns in situations where all the traditional services that you have in facilities, the transport services, etc., were not available. So we undertook an implementation project to try and see if we could work with the community around distribution of basic stuff. And we were talking about clean birth kits to be used in those circumstances. And we decided to undertake an evaluation of whether one could enhance a clean birth kit with additional interventions focusing on newborn outcomes in a circumstance where you empowered the communities and community health workers to do something about a disorder in which there was very little else that could be done through a traditional health system. Next slide. To give you an example, these newborn kits, so standard kits, and if you go forward, you would notice that we enhanced that with the addition of chlorhexidine for cleaning the cord and skincare using a common emollient that is available in many of those circumstances. And this simple combination was possible for us to do through the community distribution system. And the distribution system that we focused on was the network of community health workers and volunteers available in those communities. Next slide. And this network of community health workers called Lady Health Workers in Pakistan were the backbone of some of the emergency response in those rural populations, reaching out to families, communities, both in terms of services and also exactly the kind of intervention that I'm talking about, the distribution of commodities like clean birth kits to the communities to use as and when necessary. So what happened, in the interest of time, I'm only showing you one data slide. Next, if you look at what are the significant impacts that happen in this population, which was not massive, we had a significant reduction in perinatal mortality, largely driven by a reduction in stillbirths. But you will also notice that we had a lower rate of newborn mortality in the intervention area, although it did not reach significance. But you look at infections and their propensity in that population, the rates of omphalitis, cord infection, went down quite significantly in the intervention clusters. So in my concluding slide next, what I would like to leave you with is that the climate change impacts on women and children form a continuum, and some of these effects on vulnerable newborns and mothers in disaster situations are very poorly appreciated. These are impacted by pre-existing conditions that I've already talked about, and they require an attention to a whole range of things, including gender norms, support for mothers around nutrition, mental health, and care for newborn babies in and after birth. There are efficient and low-cost interventions that are not technology dependent. We just have no way of providing air conditioning in this kind of an environment. So absolutely building on community and primary care platforms in these kind of settings to optimize newborn care is very much part of our quest in improving global newborn care in all kinds of circumstances, including polycrises. In our next body of work, we are looking at exactly how this can be done in conflict and displaced populations. Thank you very much for the opportunity to talk to you. I'll be happy to answer questions.
Thank you so much, Prof. Zulfi, for that learning from Pakistan and insights on low-cost and effective interventions to mitigate the climate change effects. So now we'll be transitioning to our Q&A session, and we have Deborah Jackson who will be moderating the session. Deborah Jackson, over to you.
Hey everyone, thank you for these amazing talks and really a good transition, I think, from an overview of Dr. Etienne to sort of some very specific issues from Professor Bhutta. So I think we have one question. Please put your questions in the chat, in the Q&A, excuse me. We have one, and that's where are some interventions or heat adaptation methods that can be implemented outside of health facilities for pregnant women and newborns? A lot of the things that I spoke about in health facilities are things you can do with any building, but I actually want to give that question to Prof. Bhutta because I know he's got some trials going on in Pakistan in the community for addressing heat. Prof. Bhutta.
Yeah, and a lot can be done with adaptation and resilience building in community settings through low-cost technologies, through approaches, through also innovations that have to deal with how do you reduce exposures for women across the extremely hot days by innovations that have been tested in stable circumstances, things like group antenatal care, things like transporting women together from various centers to health facilities where they can get antenatal care at a time when it's not really 50 degrees centigrade out in the open. So some of those innovations also require community participation. Everything is not feasible or possible through just a delivery system that is linked to the health facilities per se, but can relate to things that happen in population settings. Now, obviously, there are also, as I mentioned, norms in many of those communities, such as women fetching water, fetching firewood, going out for many of their daily chores in circumstances and in situations where their exposure is maximal. And those can be reduced through participation of men in communities, but it requires that level of engagement and level of community awareness of the adverse impacts of climate and heat, which many communities are not as aware of. This is considered a way of life. And therefore, the added exposure that you have in pregnancy or for a pregnant woman who's malnourished, those are not appreciated. Then there are also innovations in terms of interventions that we need to be looking at in those circumstances to reduce the additional effect of heat on fetal growth retardation. There has been at least one intervention where the effect was mitigated through a nutritional intervention for mothers. And we need a lot more research around the pathways that we understand for some of the adverse consequences. But yes, things can be done with limited resources in the very environments where these are maximum.
Yeah, I mean, you hear about the white roofs. You can still paint houses with white roofs. You can have, you can build cooling areas in communities. You can also have early warning systems. So one part of High Horizons is an app, early warning app, which could be used by community health workers, or mothers, and to let them know that a heat wave is expected, and can have messaging, localized messaging. It always once again, as I mentioned, it needs to be local. It's different in Pakistan than it is in Africa, than it is in Sweden, and what women and families should be doing to protect themselves. Another question that came up that was in the chat actually was from Ami and Mass Design Group about comparing upgraded MNH units to compared to non-standard and improved minutes, and how can we measure that, the indoor heat and the outdoor heat? And I mean, that's something that we're doing, and it is possible with low cost, sort of measurement. Pascalia, do you want to speak about what that kind of thing that's happening with the like the wet bulb globe temperature measurements in South Africa, in the community and in the facilities?
Yes, Deborah, thank you so much. So we do have indoor and outdoor weather temperature monitoring at healthcare facilities. And these assist us to determine the heat exposure or none of it in healthcare facilities. And so some of the results that we have from that are still being analyzed, but I think we have seen that the levels of heat exposure are very, very high in healthcare facilities, as well as in women's homes, where we also did the same kind of work. Yeah.
Mm-hmm. And I think if you remember, I don't know if you got to note, but Pascalia's those temperatures that she showed were taken during that. And I think the one that was particularly concerning is the highest one was in the neonatal intensive care unit, and that it was running about 30 degrees through the entire period. So in efforts to keep babies warm, we might also be overheating them. Let's see, I think Mbozo, you had a question that you had translated to me. Would you like to ask your question?
Yes. To any one of you who presented, I was just curious around, sorry, just getting the question up. For countries that may not be focused on climate resilience, what public health awareness campaigns have proven successful in shifting behavior towards having that on the national adaptation agenda or just the national neonatal agenda?
I think we'll give that one to Dr. Etienne, since that's what PMNCH is all about, is advocacy and awareness raising. Why don't you, so thank you.
Yeah, thank you very much, Mbozo. So this is a really important question because it's a question about how do you set a policy agenda? So how do you bring issues at the policymaking table, and how do you raise awareness for issues like that? So part of it is really documenting the strong impact like we're doing today, and also making sure that this evidence is getting into policy window opportunities. So really making use of policy fora, parliamentarian engagement opportunities, including citizen voices. So really mobilizing a wide area of stakeholders to amplify that, the critical aspect, in this case, of heat stress, air pollution on maternal newborn health. I think the issue is also how do you speak the language that resonates with policymakers? So really building an investment case, talking about the cost of inaction, the return on investment of mitigation and adaptation to climate change for improved maternal newborn health outcomes. It's not just an epidemiological problem, it really is a societal problem. It's a problem at the level of macroeconomy. So we're starting to build that case of, what is the impact on GDP? And so policymakers really resonate to that. What's the cost of inaction over, its period of time? How much will it cost to the government and the health system? So really making sure that we all take advantages of our own traction and policy influences to bring the issue of climate change on the policy agenda. That's really important.
Okay, thank you. I think Ami also talked about some of the other work that they're doing, and we actually met with someone yesterday from Malawi, also doing some amazing work for climate. And I think Dr. Prof. Butha talked about that you need to be a bit more holistic, as well as Dr. Etienne, and that, you know, you've got to look at biodiversity, you've got to look at, you know, protection from, you know, mosquito-borne diseases, and nutrition. And so I think we have to think holistically about protecting our families and our babies. It's 2:00. So is anyone, I see there's one, looks like there's one more in the Q&A, so we'll make that the last one. Oh, this is from Veronique. Oh, we got two. Oh my goodness. So Veronique says, what should be prioritized in terms of intervention, given that the situation is becoming quite urgent and we are running out of time? So I'll give that to, and let's look at the next one, and maybe we can take those on together. Thank you for these wide-ranging, and this is from Helen Gray, thoughtful presentations. It was good to hear mention of impact of climate crisis on breastfeeding and lactation, which is often overlooked. And it was good to see to improve sustained support for breastfeeding in both high level and local levels, and key to strategy improving population resilience and first food security, as well as a strategy to reduce GHG emissions of formula and dairy industries, which do have quite a big footprint because of their supply chains. So that's an important point, Helen. Thank you. And I guess, Prof. Butha, do you want to speak about either one of those? I think they're both very important to close this.
I mean, I can. I mean, I think what is needed right now. So first of all, to answer the question, at the moment, climate is not integrated within global maternal, newborn, child health strategies. That is one of the huge challenges that we have in terms of making sure that this is mainstreamed in many communities, countries, certainly which are most affected by climate. Secondly, I would very much like to underscore that climate-related emergencies and climate-related adaptation and resilience are also not part of the humanitarian response strategy. So if you look at documentation and guidance at this stage, you hardly find any mention of climate adaptation and resilience therein. So we are losing a lot of opportunities for responding to this. The third point that I would make, Deborah, is that in the current ground reality of rapidly shrinking global fiscal space for support, and also sadly, perhaps major changes taking place at the World Health Organization in terms of reorganization and perhaps a downgrading of the importance of maternal child health within the reorganized structure. We need to find better ways of collaborating globally with pragmatic solutions to this existential crisis for many people, many of which will come from the grassroots up. So I think at this stage, what we need, and I congratulate the Nest 360 London School Initiative, the partnership with UNICEF, as at least initiating something that we need to have wider discussion on. How do we bring things together? How do we innovate? And how do we make sure that we don't get paralyzed by analysis, that we find incremental gains in almost every circumstance, whether they are urban or rural settings in Asia and Africa? Many of the underlying social determinants of problems that I've talked about are the same, but the solutions may require some contextual adaptation, and they have to come from local circumstances, health systems, governments, who have to work with things with very limited resources over the next few years.
Thank you so much, Prof. Butha. I think your comments remind me of the Climate Health in Africa conference, which was held last November. And at a plenary session, a representative from the Africa CDC said, we have not contributed as much to this problem, but we need to lead the way to fix it. And I think for ourselves and to protect. And so I think that brought that to mind, and that's something that we all need to think of. I want to thank you all very much. Thank our speakers, thank the participants, and thank Nest 360 very much for including climate in their agenda. So thank you, everyone.
Thank you.